Okay, you all met our next speaker, Judy Garber, this morning as well, and know that she is a associate professor at the Dana-Farber Cancer Institute at Harvard Medical School. Dr. Garber received her MD and Master's in Public Health from Yale, and then trained in medicine and oncology at Harvard, and then clinical epidemiology at NCI. And after all that training, she decided then to take a job at Dana-Farber, as I indicated. She's been interested in conducting research to identify individuals at high risk for breast cancer on the basis of genetic factors and on the methods to develop tools to attenuate that risk. She's also, as you heard, I think this morning in one of her comments, her interest in trying to understand how patients perceive the risk of cancer, which is an intriguing sociological and psychological issue as well. And she's been interested in Li-Fraumeni hereditary breast and ovarian syndromes and HNPCC. And today she's going to talk to us about breast cancer genetics, clues to tumor biology. Dr. Garber.
Thank you. You know, when people read where I went to school anymore, it seems like ancient history. I can hardly remember. Well, thank you for the honor of this invitation to participate in this. I'm from New Jersey. Actually, my dad still lives here, although we live in Atlantic City, and you'd think if that were true, I'd understand probability far better than I do. Margate, anyway, close by. So I often give a talk very much like Tim Rebick's talk, and I use a lot of Tim's data. But because Tim was giving that talk today, I decided to try to talk about some other work that we were doing. But I started out with a little review. Just to remember, and we heard this morning about a family with BRCA 1 and 2 mutation. And in this slide, which is not as attractive as Tim's, I was very sensitive, I say, just to remember about risk. Although one of the values of a slide like this, which graphs breast and ovarian cancer risk over time, is to remember that risk is something that is present in these individuals over time, which is something that's always a little hard to discuss. You want to give the full magnitude of the risk, the 50 to 85% risk of breast cancer, the 20 to 45% risk of ovarian cancer and BRCA1 that Tim showed, but you don't want people to feel like cancer is something that's about to happen to them every day. And in the struggle to think about prevention, you have to have a sense of how much risk you have in defined periods over time, over a year, over 5 or over 10 years, over the reproductive years versus the later years. And that's a lot of numbers to digest for any of us. And Tim talked about the fact that there's so much work trying to look for factors that can modify risk. So it should be encouraging from a clinical perspective then that being told you have a mutation does not tell you exactly your fate. It does say that your risk of cancer is higher. It doesn't really say whether you'll develop breast or ovarian cancer or both, or which would come first or which age, and at least there are other factors that can influence that risk, although certainly not all the factors on this list are modifiable or under individual control. Now, that's true for breast cancer in general in the population. Most of the reproductive factors that have been established as being linked to breast cancer, and Dr. Levine talked this morning about hormonally related factors, most of those are not really things that we control consciously from a breast cancer point of view. Age at menarche is related to many factors in the culture that obviously before we're thinking about this, even age at first pregnancy mostly does not happen in the context of, well, I ought to do it this year because this will lower my breast cancer risk compared to waiting 2 years from now when I really think it would be a good time. And the most powerful data I think that came about modifying risk are the data on oophorectomy. That this should, as Tim showed, reduce the risk of breast cancer so substantially by more than 50% if performed in women at 35. Now that's got an enormous cost, but it does have a profound effect on breast cancer development. And as part of this talk, we'll focus on, there's a lot of mystery there. Not completely. We've always thought that breast cancer was related to hormones, but because we know that so much of the breast cancer burden in BRCA1 carriers are tumors that do not express estrogen receptor, it is surprising, if so, that removing hormones, that influence protects women against those breast cancers as well. That's unique in breast cancer biology at the present time. And it is a powerful effect, as Tim showed, a reduction in risk of 50%. That's substantial. There are very few interventions that we have in medicine that affect any risk by 50%. And not to duplicate all of this, but what do you do with mutation carriers in managing risk reduction, since that was part of the title here before we move on to thinking about treatment. And we already talked about the fact that we have surveillance, we have surgery, we have chemoprevention. And I wanted to mention just something about breast MRI because it's been in the news so much lately with the publication of guidelines for MRIs. This is another place, and I think one of the themes we've probably heard today about many things is that we're often in a place where we have a little bit of information, but not quite enough to feel that we can give full guidance to women trying to make decisions or patients in general. A little technology, and suddenly we think we know what to do, but usually that's not true. These are the data from a study in Canada, which was one of 5 large studies trying to look at the best technology for detecting breast cancer in women and families with mutations. And so they did what you would do in a study like that. They had women come in on the same day. They got a mammogram, an ultrasound, a breast MRI, an examination. And what they showed was, and I do have a pointer here somewhere, that the sensitivity or the chance of finding a cancer if it was present with mammography in the first year and the second was really remarkably low. The figures we tell the general population is that mammography detects 85% of breast cancers. This was half of that. That was the figure for MRI. On the basis of data like this, that the sensitivity of MRI was better, there has been in at least one set of guidelines a recommendation that we should follow our patients with mutations using breast MRI. I take care of these patients, I'm happy to do this, but I have to say that in general our standard for screening tests is not just that you can find more, but that it makes a difference that you do so, that the outcome changes and that patients either live longer, that is the survival is actually the bottom line, or at least perhaps that you diagnose their cancers earlier. We don't have such data for this group, and these are the best MRI data we have. After this, it's almost all extension from this group of patients. For ovarian cancer, we have almost nothing. And because we have really such an absence of effective screening strategies, the move toward prophylactic surgery has been even more urgent. Ovarian cancer is very insidious in its presentation and most of the time is found at an advanced stage when it's incurable. So it is easier, certainly, to consider recommending prophylactic surgery for women when you really can't offer them any real hope of early detection, and I think most people would agree that neither ultrasound nor CA-125 blood tests have really been shown to be effective in any population, including this one. But there's the breast data. We'll skip that now, sorry. And Tim's data on hormone replacement, which is obviously a huge quality of life issue. If we're going to take 35-year-old women and make them menopausal 15 years early, we do have to think about the consequences of that, and there are substantial consequences. Now, for these patients, the trade-off, it may be cancer mortality from breast and ovarian cancer, so it's not that we don't think it's worthwhile, but we do have quality of life issues to deal with. And these are, as far as I know still, Tim, the only real data that speak to the safety of this. And you can see that, unfortunately, they're based on still a very small number of patients. I think ours are in here with Tim's, and no uniformity of hormone replacement even within categories. So this is nothing like the kind of data we usually like to use to advise patients about something that is a fairly complex interaction in this case. But one of the things I started to mention that I think has been really an interesting piece of this, and when I got into this stuff, it was because I assumed that finding hereditary cancers, you mostly would have models that would allow you to think more about cancer overall, and never expected that really the cancers that people found that developed in the setting of various mutations would really be different one from the other. That was very naive. These are data from Will Folks that show that women with BRCA2 mutations, 80% of the time, regardless of age, get ER-positive breast cancers, hormone-sensitive or hormone-driven breast cancers, whereas in BRCA1 carriers, among younger patients, 80% of the time, the tumors are ER-negative. They're also they're estrogen receptor negative, they're progesterone receptor negative, and they're HER2 negative. These days, the triple negative tumors we heard about before. But it is interesting that as women get older, even with BRCA1 mutations, there is a shift back a little bit towards estrogen receptor positive tumors. And I don't think we actually know yet whether that's because really that just happens to be true. Some BRCA1 related tumors are ER positive, more of them as you get older, or whether these women are getting sporadic breast cancers as they get older, and sporadic breast cancers tend to be ER positive, and maybe they're not related to their mutation at all. But I don't think yet we know the difference. This is one of the many ways of looking at the role of tamoxifen, and I think it just points out, as you've heard in several hints in these talks, and Tim mentioned that, and Laura Badveer also mentioned that tamoxifen certainly is a therapy that's been effective only in ER-positive disease, either in treatment or in prevention for estrogen receptor-positive tumors. If it prevents estrogen receptor-negative tumors in BRCA1 carriers, then that is also unique in biology, and it's not clear how it does that. This is from a study published by Steve Narod looking at women who had breast cancer and had as part of their management either oophorectomy or tamoxifen. And they all did have mutations, although the data was collected before they were aware of that mostly, and showed that women who had either oophorectomy or tamoxifen were less likely to develop a second primary breast cancer than women who had neither. In fact, in these data, tamoxifen's more powerful. But the confusing question is, why were all these women taking tamoxifen? In general, we would give that only to estrogen receptor-positive breast cancer patients in the first place, and it's not clear in these data. For some reason, they can't sort that out, so we don't really still know. Now, we talked about BRCA1 and 2. There are other breast cancer genes, and I just wanted to spend a minute mentioning that the question of how to look for genes has come up more than once today. Tim mentioned certainly that it's unlikely that there are a lot of very powerful genes left like BRCA1 or BRCA2 that would explain primarily families where breast cancer is the disease. That's what they get, mostly breast cancer, only breast cancer, as what we've seen. We've heard about Li-Fraumeni surprisingly often for a rare syndrome today, but that's a disease where P53 is accountable and where the condition it's in there, but where the condition includes breast cancer, but many other tumors, many other tumors as well that I think, at least I'll have to ask Dr. Levine, but I think only Ewing sarcoma does not involve P53, so it's a wide open field out there. P10, ATM, CHEK2, many of these genes are involved in DNA repair, and I think the startling discovery of the last several years was that this entirely unsuspected syndrome, Fanconi's anemia, a rare condition, an autosomal recessive condition, would be linked to the BRCA1 and 2 pathway. And that is because we knew about the genes before we understood what they did, but BRCA1 and 2 are involved in DNA repair and in maintenance of the integrity of the genome in repair, and they are part of complex pathways. Now, of course, you can draw any one of these pathways with your favorite gene in the middle. So I didn't, but there's BRCA1, P53, the gene for Li-Fraumeni syndrome, CHEK2, a gene involved in this. I don't think MDM2 is on here, although I should look for it again. CHEK1, many others, all have been looked at. They have not been breast cancer genes like BRCA1 and 2. It's not totally clear why that is true. After all, they're all in the same pathway. They're all very close together. They interact quite closely. They do have some risk. BARD1 and BAC1 have been linked, but not in any way at the magnitude of the others that we see. So it's not that there aren't these genes, but they don't account for much breast cancer. And one of the, this is just Li-Fraumeni with breast cancer, but with multiple other cancers as well. So breast cancer is not the only issue. It does make the management of BRCA1 and 2 carriers seem relatively simple by contrast. This is a child with Fanconi anemia. This is an internet-based picture, not one for which I have specific permission, but taken from the web. They have very specific findings, abnormal thumb, skin findings, and particular findings that if you radiate their cells, the chromosomes do all kinds of very funny formations. And this has been the basis for the diagnosis of Fanconi anemia for many years. And what was surprising was the identification of this kindred from my colleague Alan DeAndrea at the Dana-Farber, who had classic Fanconi anemia, and this was the child who had leukemia and had, as it turned out, mutations in both copies of BRCA2. So BRCA2 then was one of the Fanconi anemia genes. There are now 14 Fanconi anemia genes. In this family, the parents were shown each to carry a different BRCA2 mutation. In fact, we've worked up one of these families, and there is certainly mutation, although there's very little breast cancer in the rest of the family. Raises interesting other questions about the nature of these particular mutations. The other siblings, too, are carriers. Here are two other kindreds identified in New York who had the same subtype of Fanconi anemia, D1, with different but mutations both in BRCA2. These children had Wilms tumor, ALL, and medulloblastoma, solid tumors not generally considered part of the syndrome, but part of this syndrome. And they're raising other questions about the importance of these genes in solid tumor development as well. This is a diagram that Mary Claire King published lately trying to show something about the connection between these pathways. So DNA repair was known to be defective in Fanconi anemia carriers, but not thought to be so related to breast cancer. And now there are a whole family of genes. This is the D1 subtype NJ. When a gene is identified in the pathway now, one of the first things people do is go try to see if that gene is responsible when mutated in both copies for a Fanconi subtype. So such a rare syndrome as Fanconi anemia now has 13 different subtypes, and they're not all fully defined, so undoubtedly there will be more. And these genes, some of them depicted here by their relative size, also related to breast cancer. This is just the most recent one, which came from David Livingston's lab, and this collaboration with us and the group in Canada looking at PALB2, a gene that was found to be intimately related to BRCA2, hence the name, mutated in these families. And these clearly are breast cancer families, very dominantly breast cancer families that have a BRCA2 mutation, a PALB2 mutation, this family, with a child with Fanconi anemia. I'm not sure clinically how to advise this family, and I understand that next week I'm going to see a member of this family whose relatives were tested in Canada, had a mutation detected. Just takes us back to this morning. We can certainly send her sample to Canada. We can get a genetic result. If she's positive, I'm not sure what I can tell her yet about her risks related to this, but I can tell her whether she has it or not. I'm not sure what will come from this at this moment, but certainly it takes you back to now much more organized systems where you can quantify all of this. But the link between the susceptibility to breast cancer and to other DNA repair-related syndromes raises all kinds of other possibilities. Now, Laura Vantveer showed you this morning some much more advanced and complex chips, maps like this. It really can't give a talk anymore without one of these, but this is one of the papers from 6 years ago now showing the difference between BRCA2-related, BRCA1-related, and sporadic breast cancers. And the difference in this slide, where there are genes, some are on, some are off, to someone like me, is that clearly there's a difference. Of course, this particular chip had estrogen-related genes on it primarily, so you would have expected that the BRCA1 tumors would not have a lot of expression in the estrogen-regulated genes, since I told you most of them were ER negative. So this would be an expensive way to show that, but certainly a systematic way to show it. And here's the same slide I showed you before, looking at the difference in tumors. Now, this is really true. These are some epidemiologic data that Jeff Weitzel put together with Steve Narod, looking at second tumors, asking, is this an accident, or is this true that individuals predisposed to ER-negative breast cancers once would get the same type a second time? And mostly they did. If the tumors were ER-negative the first time, they'd be ER-negative also the second breast cancer in a BRCA1 carrier, versus BRCA2 carriers, where most were concordant ER-positive the first and second times. Not always, but primarily. And looking at the histology of the tumors, asking, are they different? So BRCA2-related tumors so far really look like sporadic breast cancer, and there are no special features that would help you distinguish them if you looked under the microscope or by immunohistochemical staining for various proteins or genetically. But BRCA1 tumors, at least those triple-negative tumors, are beginning to sort themselves into a subtype. So Laura talked this morning about the 5 subtypes of breast cancer, and maybe there are more, and undoubtedly there are many ways to subtype all these tumors. But here is another fingerprint, and at the bottom, clustering in this area, are the BRCA1-related tumors. These are the BASAL-LIKE subtype that we talked about, triple-negative. They tend to be poorly differentiated, high-grade tumors, ugly under the microscope, and look relatively aggressive, although, as Laura pointed out, within that category, you have to be a little careful. So we heard before about hepatitis B and hepatitis C. When I was in training, that was non-A, non-B. That means we couldn't distinguish C and D or any other hepatitis subtypes, and I'm sure that the same is going on in this area. But at least for BRCA1, many of the tumors are clustering down here, and this is what they are like by their features otherwise. In fact, we looked in just a cohort of patients with triple-negative breast cancers and asked, are they more likely to have a BRCA1 mutation than we would estimate just looking at family history or other features, and find that in general there's about a threefold increase, that someone with a triple-negative breast cancer and the same family history background is 3 times more likely to have a mutation than someone with a different breast cancer subtype. Clinically, it asks us whether we should now be thinking about pathology as a feature when we see patients that should lead us to think about testing more than we currently do. There's some very interesting epidemiology about these tumors altogether. So in breast cancer epidemiology in general, we've tried very hard to predict breast cancer risk from hormonal subtypes and from family history and various questions that everybody fills out every time they take a mammogram as if they're going to change from year to year. But it looks like most of what we've been able to predict with our usual breast cancer risk factors have been estrogen-sensitive breast cancers. Triple-negative tumors, for reasons still not clear, turn out to be more common, disproportionately common anyway, in the African-American population and in Africa, in the African population. This is not because of an increase in BRCA1. It is true in general, however, and it's raised a lot of very interesting questions about tumor biology, but also about lifestyle factors, et cetera. And we don't know whether these tumors behave all the same way, but they are, in fact, more often triple negative. Now let's go back to the tumors themselves. If you radiate the cells of BRCA1 minus tumors, you get the same sorts of chromosomal pictures that you got from the Fanconi anemia cells. And in work from Dan Silver, who's in David's lab, if you radiate the cells of BASAL-like tumors with BRCA1 intact, you get similar chromosomal formations, raising the question of whether these BASAL-like tumors and BRCA1 tumors might share some very basic mechanistic similarities, even though one has intact BRCA1 and one does not. And a large focus of this laboratory at the moment is on trying to sort out the various ways in which this might be true. Sridhar Ganesan, who came here from David's lab now to New Jersey, is working on these issues. And we've started to ask ourselves whether there might be treatment implications of identifying the molecular defects in these tumors. Now, we don't know, of course, that all BASAL-like tumors are related to BRCA1, but some of them might be. Here are some data that add to that thought that tumors radiated, these are our BRCA1 deficient cells, show specific kinds of defects in DNA repair. Mitomycin C is a chemotherapy drug that causes double-strand breaks in the DNA, the same kinds that BRCA1 is needed to repair, and you can show specific sensitivity of the cell lines to these. These are cell line data, not ours. This is a BRCA1 minus cell line that shows remarkable sensitivity to platinum and resistance to adriamycin and Taxol, 2 drugs that are commonly used for breast cancer treatment. Platinum is a drug that was used long ago, was developed at the same time as Taxol, but it was more toxic and it didn't get much foothold in breast cancer when Taxol was generally so much more effective. These 2 other cell lines are not BRCA minus, and they show the much more sensitivity to the agents more commonly used. But on the basis of observations like this that now have been made in several cell lines, and this observation that can only look good to an oncologist, I think. These are data that women with BRCA1-related ovarian cancer did better, relatively speaking, than women with sporadic ovarian cancer, and platinum is actually the basis of treatment in ovarian cancer. So these women had all been treated with platinum-containing regimens, and the BRCA1 carriers did better. So that emboldened us to think about a clinical trial. Now you can imagine that it's a pretty good leap to go from cell line data and theory to decide to try anything in patients. And these patients were different. Usually when you do this kind of work, you work with patients who've had all kinds of treatment and have had much of what will make the biggest difference for them. But these patients were part of a study of neoadjuvant chemotherapy. So these were patients who were newly diagnosed with breast cancer, had not had any treatment yet, And they received platinum for their first chemotherapy with the tumor still in place, so that you have a chance to observe whether this chemotherapy works, whether the tumor cells are sensitive and in fact disappear, or are resistant and grow through treatment. So they're biopsied at the time of diagnosis. They're biopsied separately for a research biopsy, so you have tissue to work on assays that will predict response to platinum. Then they get their platinum for 4 doses over 12 weeks. That's 3 months. So it is either a delay in the standard treatment or a time to get additional treatment. And then they go on to get surgery and their standard treatment. And these are just some of the assays that are collected during that time. Now, we did not invent this method. Neoadjuvant chemotherapy is used as part of standard of care to try to shrink tumors so women can have less surgery. But from the research perspective, many groups are using this approach just to have a chance to see whether what you're doing is right. Otherwise, we mostly give women chemotherapy after the tumor is out, and we hope that it was the right one. And in this study, we had 6 patients whose tumor, this was only 28 patients, it was a small study, but six of the women in this study who received platinum had their tumors disappear completely. From other data, from other neoadjuvant trials, achieving the pathologic complete response puts these patients in a category in which their likelihood of long-term excellent outcome is very high, whereas those patients who don't achieve that generally go on to have more problems. Now, these patients will receive fully standard chemotherapy subsequently, so they had no less treatment than anyone else, but they did delay that treatment. In fact, they had additional treatment over other patients. And as you know, perhaps, when we treat women with estrogen receptor positive disease, they get chemotherapy often plus hormones, hormonal therapies, tamoxifen, and other strategies now. Women with HER2 positive disease get chemotherapy plus Herceptin. In triple negative tumors, we're all looking to find out what the plus should be. What else should it be? I don't think it should be platinum, but platinum does work, and it did fit the model. And in fact, the 2 women with mutation carriers in this trial did both achieve pathologic complete response, which is what we would have predicted should have been true, but certainly might not have been. And that's just the illustration of one patient whose tumor was visible on MRI before treatment and was not visible before surgery. Now, this is a slide with a lot of animation. Just to remind, I'm sorry, I should take all this out, borrowed from Andy Tutt. Looking at another direction, just to let you know that this is coming. This is the diagram of homologous recombination repair, when specific kinds of DNA damage is caused that breaks both strands of the DNA. This is where BRCA1 has its main role. But when that is intact, and it's intact in individuals generally who have even only one normal copy of BRCA1, but in the tumors where you've lost the normal copy of BRCA1 and have none, this is the dominant problem in the cells. This is what platinum actually works on. But it's also true that when this mechanism is out, that single-strand breaks in the DNA become something, again, that the cell now has to contend with even more often. So in normal cells who have BRCA1 intact, the repair of double-strand and single-strand breaks is standard operating procedure. But in cells that have no intact BRCA1, then cells that develop single-strand breaks require an enzyme called PARP to help keep them from acquiring these double-strand breaks that they're unable to repair at all. And so Alan Ashworth's group in the UK has developed, as have others, a series of agents involved in DNA repair that inhibit this PARP enzyme. And the theory is that PARP should, that they should, the theory is that they should particularly be effective at killing cells that already have a defective BRCA1 or BRCA2 system. So in individuals who have inherited defects in BRCA1 or 2, whose tumors thereby should have no functioning either BRCA1 or 2, PARP inhibition may be an effective strategy for therapy. Now, this has been, I think there are now 5 PARP inhibitors that are being developed. One had data presented at ASCO, the oncology meetings, just this past weekend, showing that in a phase 1 study, so these are patients who've all had plenty of treatment and advanced disease, that in women with ovarian cancer, and particularly in those with inherited ovarian cancers, BRCA2 carriers and BRCA1 in this cohort, that they did achieve responses with these drugs alone without other chemotherapy. This would be different if we now move to treating some patients based on whether or not they have a BRCA1 or 2 mutation, because we certainly have the most expectation that these drugs should work in those women and not in women who have their breast or ovarian cancers for the usual reasons. We've never had a trial yet where we'd asked to know the germline status of a patient before enrolling them, rather than just finding that out as something along the way for some other piece of their management. But that time has come because the first trial based on these drugs alone are in IRB review at institutions around the country to take these now and look at women with metastatic breast or ovarian cancer based on BRCA1 or 2 mutations. And we're also developing some trials that will combine these drugs with chemotherapy based on the animal models. So it's not that we think we have already made the difference, although I will tell you that in the mouse models, the most exciting thing to me is that these drugs, some of which are oral, these PARP inhibitors given alone, prevent the development of breast and ovarian cancers in the mice. So ideally, we'll be able to go back from therapies, which in general are too toxic to consider for prevention, to some agents that may be targeted enough to allow us to do that. So that's really all I wanted to say. The prevention aspects of this, you really know, we do the best we can with the epidemiologic data we have, but we do have an opportunity to think differently about the biology and maybe change treatment as well. Thank you.
I think you have time for questions. Yes. Hold on, just a second. Let's get you a microphone.
Also remember, I can't see you at all, so.
Certainly the studies that you and the others have done on the role of genetics in breast cancer is very, very important. If one looks at the constellation of breast cancer patients, the study by Lichtenstein about 5 years ago in identical twins, a very large group of identical twins, indicate that environment, lifestyle factors are much more important than the heritable genetic factors. And he looked at one identical twin with breast cancer. What is the risk of that second identical twin developing breast cancer by age 75? And it's only 12%. So clearly, environment, and these are people that share all of the same genes. So what are the environment, lifestyle factors that are important? And you mentioned exercise as being one that could be important in the studies that you presented. There's also epidemiology studies as presented earlier with cigarette smoking. There's also one with coffee drinkers having a lower risk. And I'm wondering what your view is in terms of environment, lifestyle factors versus the genetics. And certainly they interact very extensively, and epigenetic factors during a person's lifetime is also, I think, plays an important role.
Oh, I think from a population attributable risk perspective, you know, we're all well aware that BRCA1 and 2 are fascinating, but account for maybe 5% of all breast cancer. If we could eliminate all of it, we'd hardly make a dent in the problem. But you know, over the last 10 years in which there's been increased funding for breast cancer research, so certainly enormous efforts to try to identify environmental and lifestyle factors that substantially contribute to breast cancer risk. It's been incredibly frustrating at that it's so difficult to find them. It's not like cigarette smoking. There is no single obvious factor. Probably the person who summarized it best, I think, is Walt Willett at the Nurses' Health Study, who calls breast cancer the price of progress. Says that, you know, we've feed our daughters better, we grow them taller, with better nutrition, they get their periods earlier, they get educated, they have their children later, and all of these factors lead to increased breast cancer risk. Not that hormonal factors are all of the story. I'm sure there are other environmental factors. There are often little clues that come from various studies. They're just very hard to sort out, and most of them are not, at the moment, still things that we can modify very easily. But that doesn't mean we can stop looking, because right now we do pretty well in estimating for populations the risk of breast cancer. We do very badly in estimating for individuals the risk of breast cancer, except when there's some glaring something like a BRCA1 mutation.
I think we need better biomarkers for environment lifestyle factors that may play a role.
I certainly
similar to the
that would be
mutations that you
hugely
see.
helpful. It's been very difficult to measure. There's someone in Boston at Northeastern who's trying to measure markers of various chemical exposures, and so far it's really a challenge. If we were able to measure those better over time, these are long-term exposures in all likelihood, given the time course of breast cancer development in the population. Maybe that would help. Anybody who's got ideas here, I'm sure we'd all be interested. It's been a very frustrating field.
Other questions?
Thanks
If
for
not,
your attention.
Thank you.